we would like to invite the next speaker, Salim Wangabi. Now you're up. I was too fast before, but now you're very welcome. Please share your screen and share with us your presentation.
Okay.
While you do this, maybe as a background, Salim Wangabi is a clinical psychologist at the Greater Accra Regional Hospital and a strong advocate for maternal mental health care for pregnant women, especially after they've gone through hardship. And he set up with his team a program for mental health for women who are pregnant. The floor is yours.
Thank you, Joyce, and thank you all for being a part of this webinar in commemorating Pre-Eclampsia Day. I think it's been very insightful listening to previous speakers from Dr. Shrofenyo to Odami and Dr. Salisu and Prof Kitty. And it brings to bear the importance of having to understand what pregnant women do go through and what we can do as health professionals to aid them. I'll start with my presentation by talking a bit about expectations of a pregnant woman. For every pregnant woman, once she has decided or accepted the pregnancy, there's a hope that she will deliver a baby without any complication, healthy. And in our part of the world, Ghana specifically, on the 8th day after her delivery, we are expected to make merry, bring gifts, and then commemorate the good job she may have done by bringing another life to the world. And then also, usually or most of the time, childbirth in any family or to any partners serves as a tightening of a bond between the nuclear and the extended family system that have these children. So then pregnancy is most of the time viewed as a time of elation, time of happiness, and because a newborn is going to join the family. However, the reality is that pregnancy does not come the same way for every woman. So sometimes it's a time that is filled with stress, worry, as well as numerous emotional upheavals and changes. Because of hormonal changes, sometimes there are mood changes, there are changes in work schedules, etc. So though the expectation is that it will be a happy moment for every woman, the reality is that we do not expect women to go through pregnancy without any challenge. And interestingly enough, research by Gray in 2006 shows that many pregnant women develop depression during their pregnancies. Why? Because there's sometimes alteration in their appetite and weight, change in sleep patterns. Sometimes there are thoughts and feelings of weightlessness, decision-making becomes difficult, etc. And so therefore, the reality is that pregnant women, even before diagnosis of pre-eclampsia, would have some psychological or mental health distresses. The World Health Organization is estimating that 15.6% of women will experience mental disorders during pregnancy. But how often are we able to pick these things as healthcare professionals? And sometimes pre-pregnancy history of depression or anxiety is also a risk profile to preterm pre-eclampsia, as Madavi noticed in his research in 2015. For non-pregnant women or males, the research is non-equivocal when it comes to the role by which the hypothalamic adrenal axis and the pituitary gland plays in hypertension. So if you have consistent or regular anxiety as a normal person who is not even pregnant, the risk factor of developing hypertension has been found out in research, and therefore people who undergo a lot of anxiety because of the sympathetic nervous system that's triggered continuously, there's going to be some hypertension. But when it comes to pregnant women, the research is a bit equivocal. Some research will say it's a risk factor, others are saying no. Why? Because the data collection and the time of assessment differ. And there are other factors that impact the quality of life of a pregnant woman, especially when diagnosed with pre-eclampsia, because the socioeconomic status she comes from or the background, her educational level. I think in Dr. Shrofenyo's presentation, he mentioned that in our part of the world, women do not get the ability to just go online and read certain things about their pregnancy and what they can do. So depending on the educational level, the socioeconomic status, there are challenges they will face even when they have been diagnosed with this condition. So in screening for pre-eclampsia, we sometimes, or most health professionals, might miss the distress or the difficulties or mental health challenges these pregnant women might have. Now, once you've diagnosed or noticed that a pregnant woman has pre-eclampsia, first of all, this is bad news. And whenever you have disclosed a bad news to a person, especially who is pregnant, we are expecting a change in mood. And when this change in mood is not managed in such a way that there's adaptive coping, we are expecting some distress, which might become depressive or anxiety later on. Research from BMC pregnancy that 1 in every 5 women with pre-eclampsia had postpartum depression, and its magnitude increases with the severity of the disease. So though maybe during the pregnancy or during the diagnosis, the mothers may not have shown significant mood changes or distress, the research is saying 1 in 5 would go ahead to develop this postpartum depression. So there's a need that attention to their mental health during those times, because maternal mental disorders are a risk factor for the child's health also. So beyond the mother, if she goes through this traumatic phase of having to deal with pre-eclampsia, and as we all require, she gets the baby through a very good intervention earlier on, the development of the child as well as the bonding between the mother and the child can be affected by her mental state. And mothers with postpartum depression have some difficulty sometimes caring for their kids or the infants or children they bring to the world. Now, when it comes to the management of pregnant women with pre-eclampsia, there are very key things I would also like to espouse in this presentation. There's a need for us to screen the mental health of these mothers as early as possible to pick any significant challenges they might be going through in the area of depression, anxiety, and sometimes post-delivery or post-pregnancy, whether there are any signs or symptoms of depression or anxiety that were missed. And in the provision of treatment, unfortunately, in our part of the world, the availability of mental health professionals to deal with the number of mental health cases we have is a bit on the low. So for most of the times, even when pregnant women have been referred to see a clinical psychologist, it may take a while before they get a date and everything. So there'll be a need for us to also develop modes by which pregnant women can receive mental health treatment or support without necessarily having to go to individual therapy. So there's a need that during this pregnancy schools and the rest, there's some education around mental health and how they can do group therapy and pick up some of these skills they will need in managing their pre-eclampsia and mental health during pregnancy. Now, there are other factors we can also consider, such as young age, marital status, family support, etc. Because most of the time, though it's the woman who gets pregnant, the support from the partner or the spouse will be needed. For most cases I have seen here in the hospital, you notice that some women in some parts of the pregnancy were left alone and people expected them to be strong. But sometimes just providing them with a listening ear to vent their sadness, to vent their emotions can go a very long way to prevent subsequent disorders when it comes to dealing with the mental health of pregnant women with pre-eclampsia. The statistics are likely to underestimate the scale of the problem. So most of the time, because we do not recognize or detect them quickly or even notice them happening, we tend to say it's not there. But unfortunately, mental health might be individual rather than group related. And also because of maybe lack of some policies and partnership between relevant stakeholders. For instance, in the health sector, there are different professionals. When there's no proper collaboration between the teams, we tend to miss some of these important symptoms or challenges pregnant women diagnosed with pre-eclampsia might be going through. So I have some proposals or things I feel when we do as healthcare professionals, researchers, and stakeholders working around pregnant women, especially those diagnosed with preeclampsia, will go a long way to help mothers or pregnant women. There's a need to make known common non-psychotic mental disorders pregnant women go through. So the education, sensitization, like I said, during the maternal clinics and schools, etc. There's a need to introduce the education and sensitization when it comes to their mental well-being, what to notice, what to report, and also identify factors that predispose them to these challenges. Because like I said, based on the socioeconomic status, educational level, cultural differences, some mothers or pregnant women might be going through some difficulties that goes to exacerbate their preeclampsia or conditions, and therefore leads to other complications. And when it comes to the healthcare professional, there's a need to assess that mental health during the antenatal clinics. So here at RAGE, what we do is in our health pro systems, we have assessment tools for depression and anxiety, such that every doctor who is reviewing a pregnant woman at the antenatal clinic has the opportunity to ask these questions. And when she has recorded significant distress in the area of depression or anxiety, then he or she could refer to the clinical psychology center, where she would be given some attention and then treatment if possible. Also, even post-delivery, when they are on the ward, these systems exist to help them. And also there's a need to increase the studies, because like I said, when you look at the research on mental health, preeclampsia and pregnancy, it's a bit equivocal. You find one research saying it's a risk factor, others saying no, it doesn't play a critical role in the hypertensive or preeclampsia levels. So there's a need for us to focus more attention on research, collect the data at different intervals of the pregnancy, control for a lot of the factors, and then going forward, we can be very objective in making statements and knowing the help we need to provide for pregnant women who have been diagnosed with preeclampsia. Thank you very much for your attention. I'll end my presentation here.
Thank you very much. Are there any questions? I saw one question by Muriel Harris. I'm going to unmute you so you can ask your question yourself.
Thank you. Thanks very much for the presentations. I've actually enjoyed them. I'd like to ask a question to the last speaker, and my question is there an opportunity to develop care teams so a woman has more than just her physician or her clinician? Because I think that may be an opportunity to expand her opportunities to talk to other professionals and other professionals to identify problems early on, so that she may be seen in a more sort of holistic light than just her clinical condition.
That's very true. And here at the Accra Regional Hospital, it's one of the things we are working towards, even in the spot impact study, so that it's not just her medical team or the nurses she's seeing, but other professionals such as the clinical psychologists, the dietitians are always present to also review and provide help and assistance as and when it's needed. And sometimes also it's very important to include the significant others. This might be the spouses, the mothers, and those who also aid her in ensuring her well-being. So yes, something we encourage and work towards.
Thank you. I'd just like to make a follow-up comment about the public health component. It seems from a lot of the presentations that that's going to be critically important. So even thinking about how public health professionals can be incorporated into some of this thinking and trying to identify some of the issues, especially the socioeconomic factors or sociocultural factors that influence health, bringing them in also into the research and into the clinical practice may also help to minimize some of these issues. I actually spend much time in Ghana, so I have a pretty good understanding of the conditions there. But thank you very much for the opportunity.
Thank you for the inputs.
Adeline Tama, I see you have your hand raised. Would you like to ask your question?
Yes. Hello, can you hear me?
Yes, we can.
Yes. Salim, good presentation. The question I'd like to ask is there a follow-up structure for women identified with postpartum depression? The reason why I'm asking this, I observed labor in one of the hospitals where a lady asked us to give her 1,000 cedis and take her baby. Practically, she was selling the baby to us. So I asked the midwife, what would be the outcome of this lady? And then in the end, I observed that she was discharged. She left the hospital by herself with a baby. And I asked the midwife, so what happens? Because this woman could abandon the baby anywhere. And she's also not even in a state of mind to be discharged. But unfortunately, they told me they needed their beds. They don't have any family member. So do we have a very good follow-up structure so that our women are followed up after they've been discharged?
I wouldn't say we have a very good structure, but it's something we are working towards. So even beyond admission, there should be a system for all hospitals. So if for regular calls or check-in for these pregnant women. And also, like I said, we are working at starting this group therapy for pregnant women, mothers who have delivered, so that when they go for these meetings or group therapy sessions, they get to pick these skills. And those that are significant then receive the individualized therapy. Because like you said, sometimes the distress or the depression might not be significant enough, and therefore with a little help or skill training, she would be fine. But some of them may have moved to certain levels that might actually need a specialist to see them. And so, yes, the follow-up system is not the best, but we advocate and are still working at expanding it so that beyond discharge, there's a follow-up, there's a course them. And also because they come for reviews, I think every week or 2 weeks after delivery, we here at Rich insist that when they come also, they should do a review with the clinical psychology center to keep us updated on how they are doing and the distress they might be going through. I hope I answered it.
Okay.
The next question is for Nesia Taylor. Nesia, if you want to ask your question, you can. Or I can ask your question for you. Nesia was wondering if there are screening tools available, questionnaires that can be used to screen women for mental health disorders.
Yes, there are a number of them. Some of them actually are free online. There's the hospital anxiety depression skills. There's the Harvard trauma skill, a number of them. So if you go online, you find tools that aid you to assess. So now, assessment of mental health disorder sometimes goes beyond just using of the tools, but also observation and sometimes history taking. So that's why we say that when you do this assessment as health professional, maybe as a nurse and doctor, you look for a score. Once it's significant assessing point, then you refer to the professional in that area to also follow up. Because sometimes people who have knowledge of these tools can sometimes provide answers so that it doesn't look significant. Because one of the challenges of mental health is also denial because of the stigma attached to it. So some mothers, though they might be going through some difficulties at home or some depression, will not open up and talk about it. Because sometimes they feel, well, I don't think I would get help. Why should I open up? And so once you've seen those signs, yes, the tools are good. You start with them, you assess them, and then refer appropriately so that other healthcare professionals can take over and provide help.
Thank you. Before we introduce our international surprise speaker, there's time for one more question. And I see Frank put up his hand. So would you like to ask your question, Frank Nitako?
I hope you can hear me. I am very much impacted by this presentation, especially with the mental health side. We live in a country where mental health issues are usually relegated to the background. Mine is actually a comment, or more or less an addition to the presentation. I feel that the involvement of husbands, for example, should be intensified. But like you said, in a part of the world, husbands tend to control virtually everything that happens in the house, in the family. But we are in the hospital setup and you see women or wives, pregnant women alone coming to the hospitals and assessing the care. They're going through all the struggles alone. And the men don't seem to care because they are out there only looking for money. I feel that in a normal situation, when a woman sees the husband around, going through this stress with the husband, she becomes more fulfilled and enjoys the service than seeing the healthcare professionals. So my comment is that there should be a policy that will actually bring husbands on board to support their wives. It will be a great thing. The second thing I have also realized working in the hospital myself is the disjointed services that we see. I usually see clients going through different units, going through a doctor, the hands of a nurse, a midwife, the lab person, and it looks like each unit or department is offering the services disjointedly. Nobody seems to care exactly what is happening. I feel the time has come where, for example, in my facility, you realize that women who are in this situation with pre-eclampsia, usually you find them with their own samples, going to the lab. In my hospital, for example, a baby hospital, that clients will have to move from one point to another, frustrated, not even knowing exactly where the next point of service will be. I feel that there should be a clear system that will more or less control and monitor all these systems so that clients will not have to suffer. Already they have their depressions already. If they have to go through these services, and then the service which is supposed to make them better is even adding up to what they're going through, then I don't think it's happened. So my contribution is that there should be a policy, in fact, an intensified one, that will make sure that not just a doctor sits in his own consulting room and takes care of the patient, the nurse is in the ward or anywhere, also offering her bit of it, the lab person offers a bit of it, and we all leave the patient in degenerated conditions. There should be a way to monitor all these things so that the client will not suffer as a way of even offering services to this client. Thank you so much.
Thank you. Salim, would you like to respond to this?
No, I think it's a good comment. So like I said, social support during pregnancy and post diagnosis of preeclampsia cannot be overstated or understated. It's very important. But sometimes there's a bit of dynamic you also want to look out for. Insight to pregnancy will not be the same for everybody. And because of privacy and confidential issues when it comes to patients, you want to also seek permission from the pregnant woman as to who she wants to come in and not to draw in people who she's not comfortable with. Because though there might be a relationship, you don't know what's going on at home. So yes, it's important to bring in everyone who would be able to support them, and let's do that also with some caution, taking consideration of their privacy and confidential issues. Thank you.
Thank you. And again, thank you, Salim Wangabi, for joining us to talk about mental health, a underappreciated topic in hypertension disorders, and in part because of all your efforts, has a really steady increase on the agenda, the research and clinical agenda in Ghana, and its reflection of the world, fortunately a world where we have more attention for this. As everyone could have seen, there is a new PowerPoint up, and that's for our surprise international speaker. On behalf of the organization, I'm really proud to introduce Professor Andrew Shennan to you. He's a professor of obstetrics at King's College in London and based at St. Thomas Hospital. I'm sure he will give a more elaborate introduction himself. What I do want to highlight is that he's quite familiar with various sub-Saharan African settings and clinical settings based on his childhood that took place in a number of sub-Saharan African countries. Professor Shennan, the floor is yours. Very welcome.
Good, thank you, Joyce. Can you hear me all right? Good, fantastic. So I'm going to give you about 20 minutes, I think, if that's all right, 20, 25 minutes. I saw on the program, so if you're happy with that.
Yeah, that includes the Q&A session. So
all right, so I'll keep it down a bit to 20 minutes. Thank you. And so I'm absolutely delighted to be asked, and thank you for inviting me to come and talk to you, because I'm a firm believer that you guys are working in the most important parts of the world, and you are the ones that are going to make a difference. So the opportunity to be able to talk to you and share some of the stuff we do and thoughts we have is just phenomenal. And I also just wanted to congratulate APECGH Ghana, because you've kind of led the world in setting up a very functional organization, and we've been really looking forward to engaging further. And in fact, we're trying to emulate exactly what you've done everywhere else. And I'll talk a little bit about those initiatives during this talk. So I just wanted to kind of acknowledge that and congratulate you all. So I'm an obstetrician, so I work in London. I'm an academic, so I kind of have a university appointment, and I spend a lot of time doing research. And one of my passions has been to look at problems related to maternal mortality. And one of my other great interests has been in preeclampsia. So I've kind of married those two ambitions to try and look at preeclampsia in low and middle income settings, sort of the global south and so on. So I just really wanted to, I'm sure you know, you're very familiar with preeclampsia, but just wanted to very briefly go through some concepts around it, which is why I think some strategies are good for us in preventing the problems in a global setting. So we all know preeclampsia is this sort of has this insidious onset that is very difficult to know when it's going to happen. But we do know that the pathology of it starts quite early on, probably related to the placenta. And then at variable times, people will get high blood pressure and protein. And one of the hallmarks of safety is to identify blood pressure and or proteinuria in order to target those who need attention. And that strategy works incredibly well. So a huge amount of what we do is about accurate determination of blood pressure and protein and making sure those people are seen regularly. So that's a key component. And what is pretty common is that you don't always get symptoms afterwards, but you do have a crisis. And the crisis often happens in a few days, particularly with early onset preeclampsia, but certainly no more than 2 weeks, even with late onset preeclampsia. And that crisis means something to the mother, something to the baby that results in death, requires delivery to prevent that. And so therefore timely sort of identification and getting the baby delivered is what is key. And that is a very tight time frame. In fact, we've just finished a trial in the UK called Phoenix, published in the Lancet recently, showing that if you get preeclampsia at 34 weeks, the average time to a disaster is only 3 or 4 days. So we know that if you get the diagnosis right, you can reliably know that person's going to run into trouble, and delivering them, even if they're premature, may be justified because there'll be a disaster otherwise. And we've used this strategy in terms of developing new blood tests, which I won't go into today, but that's something we're working on in the UK. But what I will go into is some of the issues around mortality around the world and how it's been reduced. We're very proud in the UK that in recent years, from 2008, we have dropped the mortality in preeclampsia to virtually nothing. So 1 in a million people die from preeclampsia, and there are virtually no substandard care now. But in the 1950s, up to about the 1970s, the way that we improved things was basic healthcare structures and identifying people. And our universal healthcare structure, making sure everyone gets a check, has been the hallmark to success. So we haven't got a magical treatment for preeclampsia. We just identify people and deliver them in a timely manner. And it's very rare for sophisticated care like ITU care to make a difference. And so this is a really important principle. And when you go to the rest of the world, you can see that Africa and Asia really has the sort of lion's share of the morbidity and mortality of preeclampsia. Yet the success in the high-income countries is dependent on healthcare structures. So even in the UK, we have 15 times lower mortality than the US. And I think the difference between those two is not the sophistication of care. It's just that we have universal health care that everybody gets, which does not happen in the United States. And that makes a massive difference to the success of mortality and prevention in preeclampsia, and a very sobering lesson, I think. But those lessons can be translated around the world. And I just want to share with you this data, which is data from one of my trials where we've looked at death rates accurately, prospectively in low and middle income countries. And this is published in March last year, showing that mortality does alter a lot according to hypertensive disorders around the world. and some countries will be, 4 or 5 times worse than others in a low income, so that there are big differences, and they are largely attributed to simple measures like just getting blood pressure measurements to the right people. But I want to show this data in the context of coronavirus, because, the whole world now is having to deal with this problem. In the UK, it is rare for women to die from pneumonia, and it's rare for them to die from influenza. And in this particular bar, you can see the dark bar are those non-genital tract sepsis deaths. And what I've done is I kind of looked at this in a little bit more detail. I thought you might find it interesting in the current pandemic. You can see from this graph that the people who die from coronavirus so far are those who tend to be older people. So those over the age of 60, the rates escalates. However, if you compare it to influenza, so the pandemic of 1918, you can see that women of reproductive age between 20 and 40 were much more likely to die from influenza than they were from coronavirus. So to me, this is quite reassuring for pregnant women. Pregnant women on the whole do not have a very high risk of dying from this. And the reason I mention this is we have to put this in perspective to preeclampsia. Now, I've just worked this out recently that the deaths from sepsis in the UK from pneumonia and influenza is very rare. So 1 in 220,000 people die in pregnancies. We've worked out from our UCOS data set from the UK, where we had 80,000 deliveries in 6 weeks, there were only 5 maternal deaths from coronavirus. So that means the chance of dying from coronavirus is 1 in 16,000. So that's pretty low. It is true that women from different ethnic groups were more at risk, but only 4 or 5 times more at risk. So even if you took that into account, the deaths from coronavirus are relatively modest compared to, for example, the average deaths from preeclampsia. So if you take the average deaths from low and middle income countries, it's 1 in 2,000. So it is literally 8 times higher than the coronavirus deaths in the UK. And we haven't got a cure for coronavirus, and our treatment doesn't necessarily make a difference. So actually, I think we have to keep this in perspective, that treating preeclampsia in the environments you work in is probably more important than coronavirus. That, I think, is a fact. I'm not saying coronavirus isn't terrible and we have to be careful, but what we mustn't do is stop normal antenatal services because of this problem, and that is obviously a challenge with this happening. And what's happened in the UK is that we're down to 1 in a million, and we're just really worried people aren't accessing care and that the death rates are going to escalate now. So this is something that I just wanted to kind of point out to you. And just to share with you our experience in London, in our hospital in the UK, we've only had 30 positive cases, and we are in the middle of one of the worst areas in London, London being the worst part of the UK, ahead of the curve of everyone else. And other than New York, I think this is one of the worst experiences in pregnancy, yet it's not that bad. In the last 2 weeks, we've tested 180 women coming through the door who've been admitted. There wasn't a single positive case. So our strategy of isolating seems to have worked, and we only had 3 sick women and nobody died. So I think this is kind of a good news story, and virtually no vertical transmission to the baby. And again, if you look at this now, you can see that we've only had a sporadic number of cases over the weeks. Now, I wanted to talk a bit about prevention of preeclampsia. I think you all know the aspirin story. We know that low-dose aspirin prevents preeclampsia if given to high-risk people. I just wanted to share a couple of slides with you that that may be of interest. We know how it works by this favorable thromboxane prostacyclin imbalance. This data, I think, is worth sharing. I think you may know it, is that if you give aspirin at nighttime, people do better. And we're not entirely sure why, but you can see for all these outcomes, they are better if you give aspirin at night. And because that's such a simple thing to do and to recommend, it's something that that's worth clinicians knowing. We also know that the dose of aspirin might be crucial. In these studies, we know that if you start giving slightly higher dose, maybe up to 150 milligrams, the outcomes may be slightly better. And so that's something that we are now considering in the high-risk cases, although 75 milligrams has the best safety profile. And in the Aspirin study, which is a European trial mainly, giving 150 milligrams early on from 12 weeks, finishing at 36 weeks, and giving it at nighttime, targeting it to people who have problems indicating they're at risk of preeclampsia does mean it works well. And you could see that in this study, there's a 90% reduction in the early onset preeclampsia, which is what we really want. And also in the preeclampsia that occurs before 34 weeks, an 80% reduction and a 65% reduction before 37 weeks. So all a good news story, including reductions in things like abruptions. And this paper I think is quite interesting. So this is actually in a low income setting. You could see that aspirin was given routinely to all nulliparous women in a low income setting as in an attempt to reduce preterm birth. But the way it reduced preterm birth was by reducing the need for early delivery from the hypertensive disorders of pregnancy. That was its main action. And you can see in this slide that there's an over 60% reduction in early onset hypertensive diseases in women who routinely got 75 milligrams of aspirin from early pregnancy in a low income setting. So these authors are advocating that maybe we should be giving out low dose aspirin more readily. The challenge, I think, for low income settings is targeted, getting it, the pharmacy of it and getting it to the right people early enough. So, but it's interesting data. I'm going to move on to some of the work I've been doing with the cradle device. So we actually were very keen on developing something that was practical for a low income setting. My passion for this really came when I worked in South Africa in the late 80s and saw the mortality in preeclampsia that is very prevalent in Africa. And I came back and worked with Michael de Sweet here and learned about blood pressure measurement. Cut a long story short, I was seconded onto the WHO and we came up with a bunch of criteria for a simple low resource blood pressure device. And this is the criteria that the committee I was on stipulated. And I actually set out to make this device with one of the companies. And you can see this is obvious stuff, a cheap device that works well, is robust and is accurate and so on. And the idea was that this device would help dictate who needs to be transported, help the people who do the training, and dictate who needs treatment. Fairly obvious stuff for preeclampsia. And in that trial, we actually confirmed the impact that preeclampsia has on mortality. So here's 1,000 women who died in the Cradle 3 trial, and you can see most of them were obstetric hemorrhage, a reasonable proportion were sepsis, and then another 22% were hypertensive disorders. So the vast majority, like 3/4, were attributed to these three things that require vital signs to identify them. So the blood pressure device that we created was really designed to be accurate and used in a low income setting. And here's an example of one showing a woman who just had an eclamptic fit, where her blood pressure is high on our blood pressure device, but it's incorrect and low on an expensive blood pressure device. This is from South Africa. So actually, it's really important that you use accurate blood pressure devices. I'll give you an example of why this matters. So here is a reading from Sierra Leone, where I was sent this blood pressure reading of 210 over 137, red light. And they said, oh, is this accurate? And I said, well, the machine next to it, which was their expensive ICU machine, said it was 160, 112. And I said, well, actually, we know the cradle device is accurate. You shouldn't ignore this. And actually, they did ignore it because they thought it was a cheap, simple device and their expensive ITU machine would be okay. So the next day I rang them up and I said, well, what happened? And they said, well, actually, this woman went blind 2 hours later. And they then suddenly started to believe the very high readings. So this isn't a lesson that not all sophisticated machines are accurate, and you have to use machines that tell you when things are severe. So this device was originally created and made in China. Here is the prototype. We made sure it was accurate with our team in South Africa. We validated it, and I'm not going to go into too much detail in the interests of time, but we added in a mini USB port so it can be charged by mobile phones anywhere in the world. We checked it in Tanzania, Zimbabwe, and Zambia. We added on the traffic lights so that people would understand when things were incorrect. And we made sure that if the blood pressure was abnormal, it was amber. If it was very high, 160, 110, it was red. And we assessed it for shock index as well. Now, again, in the interests of time, I won't go into this in too much detail, but basically shock index is when you divide the pulse by the systolic blood pressure. And again, to cut a long story short, if your heart is going fast and the blood pressure is dropping, you have a high shock index. So if you're losing blood or if you're septic, that is what happens. We actually evaluated the shock index in various countries around the world, and we showed this, which is that if you have a red light, you're tachycardic with low blood pressure, you are much more likely to have a severe event. So much so that a red light meant 1 in 3 women died, 1 in 3 had major surgery, such as hysterectomy, and over 60% were going to ICU. So we thought this might be quite a good tool, and we used it in 1,500 women in South Africa. And again, just to show you that South African data of 1,500 women with preeclampsia showed that 20% were dying, and more than 90% of these deaths were antenatal. And what this taught us was that by delivering babies early, you're going to save most of them. So when you're worried about a baby being delivered early, you have to realize that they've got babies tend to die antenatally, and the way you save them is by delivering them. So there's a tension between prematurity. Now, some of the things we found in that data set was that teenagers were much more likely to get eclampsia. Women of low BMI were much more likely to get eclampsia. And these are things that aren't the same as risk factors for preeclampsia. And I think these are important things to remember when you're looking at risks of eclampsia in your antenatal population, particularly in an African population. Now, I'm just going to move on and show you how this blood pressure device was assessed all over the world, many countries. And interestingly, if the untrained healthcare workers were much more likely to be using it properly a year later when we went back and looked how they were using it. So this is a publication showing how just basic blood pressure technique is used well by untrained people, and that the nurses and doctors actually started to go back into bad habits. We did a trial with this device all over the world, and I just wanted to very briefly share with you some of the results. So here, this was published in Lancet Global recently. We put out nearly 4,000 devices to nearly 3,000 healthcare providers, in 8 countries, around nearly 300 facilities. Basically, the training is available on YouTube, but it looks a bit like this. These are posters. In that trial, we had 2,500 eclamptic fits, we had 1,000 women die, and nearly 700 hysterectomies. And what we found was introducing the device actually resulted in a big reduction in hysterectomies, interestingly, about an 80% reduction. Overall, there was a 10% reduction in mortality during the trial. Unfortunately, we didn't have enough power because of the variability to prove that this was an effect overall. But if you looked at the different countries, there were big effects in some countries, like Sierra Leone and Lusaka and Haiti, and not such big effects in other places. But what was also interesting is when we used the device, we didn't increase the need for transfer and care. We actually reduced the need for transfers for hemorrhage, because I think the right people were being transferred rather than the wrong people. So we liked the idea that we were going to help the healthcare services and actually save money as well. And here is the data from Sierra Leone showing how the mortality steadily dropped after introduction of the device over a 20-month period, over and above what was an expected reduction in mortality. Now, I'm going to finish off by just sharing with you a couple of the trials that we've been working on in Africa. The Phoenix trial, which was done in the UK, showed that if we routinely delivered people from 34 weeks rather than waiting for them to get sick, the babies were better off. The babies were no worse off, and the mothers were significantly better off. And the mothers were also more likely to have a vaginal delivery. So there was a 25% reduction in maternal morbidity, less severe hypertension. And the babies, although they ended up going to special care a bit more often, they had no more morbidity, and actually they had more morbidity in some cases, like hypoglycemia. And here's the data showing they have more vaginal deliveries if you're routinely delivered early from 34 weeks. Obviously, delivering early in low-income countries has more significant effects. So one of the trials we're doing at the moment is balancing the advantages of delivering from 34 weeks in terms of removing risk of IUCDs and HIE and abruptions and so on, versus the problems of immaturity. So this trial is ongoing in Lusaka and Dola, and in fact, I just got a text half an hour ago saying they've just recruited someone else in Lusaka this morning. So that work is carrying on in spite of coronavirus, and we're very, very glad for that, because of the importance of hypertensive diseases. We're really hoping this will be a lifesaver. In the UK, in 900 women, not a single baby died. Already in Lusaka and Ndola, a large proportion of babies are dying at 34 to 37 weeks. So we think by delivering them early, although that's not, it's a challenging thing to do, it might be a lifesaver. And I would just say watch this space for that trial. And here's the data from our previous trial showing that for every baby that dies postnatally, there are 30 babies dying antenatally between 34 and 37 weeks. So by delivering them early, you don't necessarily cause a problem. You may be saving a lot of lives. Because it's International Pre-Eclampsia Day, APECH is doing a lot of initiatives. If you go onto my Twitter account, which is at the top there, @OBSEvidence, I can direct you to these videos. We've produced some videos in Haiti and in Zimbabwe, which are for women to look at, to try and instill the importance of breaking down the barriers of accepting care and the issues around why it's so important to accept care and be managed appropriately by healthcare physicians. And that's our HAPPY project. APECH, we are hoping that you will be a leader of this initiative. We were hoping to launch this in Kigali in June, but because of coronavirus, this has stalled somewhat. But this website is going to go live soon, and we hope that you will be able to have a domain in there and lead the way in showing the many other countries we would like to emulate what you've done in a resource that will help. So we're going to put our videos and things on here, and we'll be in contact with you to see how we can work together to lead the way for the rest of the world. I'm going to finish off by this very last editorial that we'd written. So Marcus is on the line, and he helped me with this along with Lucy Chappell, looking at the reasons of how we managed to get to this fantastic situation of only 1 in a million people dying in the UK, all the simple components that lead to that. And I would encourage you to look at this editorial if you just want to try and emulate the simple things, because they are perfectly translatable to the rest of the world. It's not sophisticated reasons how we've achieved this, it's simple reasons, identifying the right woman, delivering them in an appropriate way. Here are the resource facilities on APECH, and I just want to say thank you to all my team all over the world. Real pleasure to work with them, and I'm happy to take questions.
Thank you very much. Who of the audience can I give the floor to ask a question? Mabel, I see you have a question that you asked in the chat. Would you like to ask it?
Yes, please.
The floor is yours.
Yeah, I want to find out how long an individual would have to take the aspirin, and then also how available can we have this special machine for monitoring the blood pressures?
Okay, so very good questions. First of all, we would encourage that you start the aspirin early on in pregnancy. So 12 weeks is good because organogenesis is finished and you don't have any concerns at all about influencing how the baby's developing. Ideally, you want to start before 16 weeks. The evidence is that if you do that, you are better off and you're more likely to have a beneficial effect. And you want to take that aspirin at least until 36 weeks. And it's okay to take the low dose 75 milligrams right up till delivery. It's not going to influence bleeding. You can still use epidurals, all that sort of thing. So that would be the recommendation for aspirin. The cradle device is available from APECH UK. We've actually not got any at the moment because of the flurry of interest because of coronavirus. However, we are working hard with the Microlife to make sure that this is something that can be distributed throughout the world. So we've had a big initiative in Sierra Leone, for example, where we've just delivered 3,000 with the DFID program, and it's certainly being used in about 40 different countries around the world. However, we will work with APECH Ghana to try and get a way of getting this device available to you. So thank you.
Thank you. Isaac Boateng, I see you have a question.
Thank you.
Too. Let me unmute you so you can ask your question.
Okay, thank you very much for the presentation. I'd like to find out, in your presentation, you mentioned that the aspirin, when taken at night, seemed to be working. So I wanted to find out if there's any clinical reason to that.
Yeah, no, it's a curious thing, but it does seem to be real because people have gone back and looked at it, checked it, and done meta-analyses. There is a whole kind of science on chronobiology where they've looked at the effects of taking drugs at different times of the day and with antihypertensive medications as well. And I think because there is a sort of, you know, strokes and things like that seem to be more common at night. So certainly from an antihypertensive point of view, people are keen on making sure you have treatments at various times that may have an impact on your vasculature. Why aspirin should it's really difficult to know, but it is definitely a clinical observation. So I can't give a really hard, plausible pathophysiological reason, but because it's such a simple thing, and even if it's not real, you still get the dose for the 24 hours, I think it's something worth doing.
All right. Thank you very much.
I see Henry and Marama also has a question. Please ask your question.
Yes, thank you, Andrew. I'm interested in finding out this cradle device. How long does it continue to work with the same efficiency over time? Because that will be an interesting factor if it's given out to community health workers for services. At what time intervals do you need to kind of recheck them or recalibrate them? Yeah, thank you.
You know, Isaac, I'm really glad you asked that question because it's such an important one. One of the things we made sure was this was a very robust device. So that was one of the primary conditions, because we know that you buy cheap equipment, it breaks in a few weeks, and this is a common problem around the world. People always go for the cheapest thing, and it often doesn't last. So the device has thoroughly been checked. We checked it to a standard of 20,000 inflations to 300 millimeters of mercury, and that is the sort of factory requirement for it to work. Actually, if you get a reading from it, you can rely on it. So you don't really have to check it. The transducer remains reliable. And this idea that you have to kind of check the calibration is not actually a reality. As long as it gives you a reading, you're probably okay. And the calibration check is not an issue. Obviously, some of them will break, and they will break if they are used a lot. I walked into the hospital in Freetown in Sierra Leone, and one device had been used there for nearly 4 years, and it was the only device, and they were taking nearly 500 readings a day. So that one device had taken over 500,000 readings and was working fine. The problem was they have to charge it every 300 readings. So everyone was waiting for an hour while it got charged. So we're confident that this is quite a robust device, and you know, maybe in a year you might lose 10% if they're being used a lot, but because they're so cheap, you know, I know $20 can be a lot depending on where you are in the world, but that's not a lot to replace a device if it lasts for so many readings.
Thank you. Isaac Ampoma, can I give the floor to you for your question? Just a minute. Yeah, you're.
All right, thank you very much. I realized in your presentation there were some different types of readings. So my question is.
Oh.
Well, we've lost you, Isaac. You've gone to mute. You've gone to mute just before you asked your question.
Yeah, let me.
Just repeat your question, Isaac.
Right. So the fact that we have so many, we have a number of blood pressure machines, and therefore different types of readings, which many are ignorant of what is the right, appropriate measure for controlling high blood pressure. What is your advice? Should we now begin to advocate for a standardized machine? And if it's a standardized machine, what should be the right readings of a blood pressure?
Good. Yeah, no, excellent question again, Isaac. You're absolutely right. If there's any doubt with the equipment you have, if you're using one of these automatic oscillometric machines, what you can do is use your stethoscope and take Korotkoff sounds, and that will help confirm whether the machine is correct or not if you're worried about the reading. Your reading with the Korotkoff measurements is the gold standard, so you can rely on that. There are websites like Stride BP and other sort of British Hypertension Society that actually lists the pregnancy validated devices. And so if you want to buy them, then you need to kind of look and see what is validated. So some companies like Microlife, like Omron, have got a good algorithm for pregnancy, and you need to check it's accurate in pre-eclampsia. So ideally you want to buy one that's correct, and obviously if you want a cheap one, the Microlife device is particularly cheap, and we know it's accurate in pregnancy, the cradle device. And we don't get shares in it, we don't make money by selling it, it's genuinely there to help the world. But if in doubt, use your ears and the Korotkoff sounds to check the device, and that will confirm. You got big differences, then you say, oh, my reading is very different from this machine, I can't rely on it. So if you've got someone who you thinks the reading is or should be higher, or suddenly gone lower, just do a normal Korotkoff sound with a stethoscope.
In that case, I would like to thank you, Professor Shennan, for joining us. For everyone, the recording will be available because there was a lot of information, and I can imagine you may also want to pass this on to others to hear about it, including the known challenges we have with reliable blood pressure measurements, and that this can be a solution for this. Unfortunately, we have run out of time a little bit already, so I do want to give the floor to Linda Vonjo to close the session. If you have any questions that have not been answered in this webinar, please list them in the chat, and we'll answer them and circulate the answers through APECGH Ghana's social media channels and email. Linda, the floor is yours.
Hello, everyone. It's a beautiful day, and I'm glad we could all join in to commemorate World Pre-Eclampsia Day. First of all, I would like to thank our CEO, Koiwa Ofosuapia, who is the brain behind APECGH Ghana, which is a foundation aimed at increasing awareness about pre-eclampsia and also saving or reducing maternal mortality through education, through research, and supporting women who have pre-eclampsia. Would also like to say a huge thank you to all our distinguished speakers who made it to join us today. I know they're very, very, very busy. I know also it's a holiday in the Netherlands, but Professor Kitty and Joyce, of course, you made it to join us today and make our conference a very remarkable one. We thank you for your invaluable time spent with us and the in-depth knowledge on pre-eclampsia that you've shared with us. Professor Kitty, we say thank you very much for sharing with us your perspective on the global epidemiology of pre-eclampsia. Professor Srofeyon, Dr. Srofeyon of the Greater Accra Regional Hospital, we are also grateful to you for sharing with us the Ghana situation of pre-eclampsia, which looks a little bit very gloomy, but we are hopeful that as the years roll by, things will change for the better. Dr. Salisu, thank you for sharing with us your knowledge on postpartum pre-eclampsia, for drawing our attention to a holistic approach in taking care of our pregnant women that we'd have to consider from preconception through to postpartum period. Thank you so very much. Enoch Odami, thank you for sharing with us your new algorithm. Hopefully, as time goes on and this model is tested and validated, it may find its way into our various hospitals for use for predicting pre-eclampsia. And Salim Wangabi, thank you for drawing our attention to an area which is quite neglected in Ghana, I must say. The mental health of our women has somehow been relegated to the background, but you've drawn our attention to the fact that we need to take a look at this aspect, especially for our women who end up having pre-eclampsia. To our audience, we couldn't have had a beautiful day without you. Thank you for joining us. Thank you for your questions. That has really shaped our discussion. We look forward to seeing you again, hopefully next year. But we are always available online if you have any questions through our email, through our website. If you have any questions to ask, we are always ready to answer them. And to our team, the APECH team, thank you for putting all this together. I think that Joyce should put up the list for me. Dr. Buckman, Dr. Dorothea Obri, yes, Koiwa herself, myself, Linda, Dr. Sofeon, Joyce, Dr. Vivian Boama, thank you for putting this together. And to our partners, you have been of tremendous support to us throughout organizing this, and even from last year, APECGH Ghana, led by Dr. Joyce Brown, to UNFPA, the Ghana Health Service, the Greater Accra region, and also to APECGH UK, led by Marcus Green, and of course yourself, Prof. Shennan. We are so grateful for sharing so much with us, your rich knowledge on clinical trials and all that you have done on pre-eclampsia. We look forward to you sharing this cradle device with us soon so that we can also use it here in Ghana. All right, thank you so much to all of you, and hopefully we can see you on or before next year World Pre-Eclampsia Day. Thank you.